Well, today, John Oxley and I were absolutely blown away by Beth Brown, the operations manager at the National Centre for Sport and Exercise Medicine. Beth was also previously the Macmillan Cancer Programme lead and involved in social prescribing as part of a charity, as well as being part of GLL's health programmes in the past. The National Centre for Sports and Exercise Medicine in Sheffield's aim is to improve health through exercise and sport. So this was an ideal opportunity to talk to Beth to understand and learn from her experiences. Beth also managed to get a Churchill Fellowship and went over to the USA and Canada to study how physical activity plays a part in cancer care pathways. So absolutely lots to learn about co-location and integration of services. But we also found a broader perspective on how physical activity can play a more central role in supporting the NHS and the health of the nation. Really powerful too. Once again, some great work on show here and some invaluable lessons to be learned. Enjoy. Right, good morning. Welcome to the Conveners Podcast, Beth. Welcome, Mr. Oxley, as well.
Good to see you.
Co-presenter. Nice to have you here. Beth, thank you so much for coming down today. Really excited. We had a very long chat a few weeks back, so I know we're going to have a really good session today. So let's kick off. Can you please tell us, first and foremost, about your career to date, what you're doing now, but how did you get where you are now? And maybe intertwine a little bit about where physical activity has played a part, both sort of personally and professionally, please.
Yeah, so I started with sport. So growing up, I used to play cricket to county level, and that was obviously a big part of my life. And then went on to study sports science at Loughborough Uni. Didn't really have a plan at that point. I just liked sport and decided to study it. And then after uni, I still didn't really know what to do, but got into the fitness industry. So I started working at Nuffield Health in corporate fitness. So that worked in that field for a couple of years, and then started to focus more on health and exercise referral. So I did my exercise referral qualification, did some level 4s in cardiac rehab, and then moved over to more public sector roles. So working for GLL on their scheme. They've got a scheme called Healthwise. So delivering on some of those programs. Moved around. I lived in London at the time, so I moved around different boroughs on different schemes. And yeah, I suppose I knew at that point that health was where I wanted to focus, health and physical activity. Then decided to study a master's in public health, just to get more into that world, I suppose. And my intention at that point was to eventually work in public health and perhaps local authority. That didn't happen for various reasons. But after the master's, I started kind of taking more management roles, but still in that health, physical activity sphere, and worked on a few specialist programs. And I kind of developed a bit of a specialism setting up new programs. So one for cancer, so a program called Macmillan Move More, which was part of a national pilot at the time. So I managed one of the pilot sites, and then a stroke program, which was funded by the Stroke Association. And then I got into a social prescribing role, setting up when the funding and that kind of came into primary care. The charity I worked for at the time won the tender to deliver it, so I moved over to setting up and managing that service. So it kind of moved a little bit away from social prescribing and more into health. And
how long ago was this, Beth?
This was, I'm up to 3 years ago now.
Right, okay.
So and then I kind of got back into cancer. So cancer had always been my passion of all the things I'd worked on.
Any particular reason? Or
just the impact it was having and on people, but also the health professionals, and how much scope there was for change, I think. A lot of people, it was still quite unusual and unnatural, that connection with physical activity and cancer treatment. But, you know, with that kind of change, embedding that in to people's lives and to the health system, it made such a big difference. So then I started working for a charity called Breast Cancer Now, and that was kind of more, again, away from physical activity, more on the support side. So I had a project management role there, and then moved into my current role, which is at the National Centre for Sport and Exercise Medicine. So I was quite desperate to get back into the exercise, physical activity field, and then this role came up in Sheffield, where I live now. So it's kind of perfect fit, really.
So just on the physical activity side, on a personal level, are you still playing cricket or any? What do you do to keep fit?
No, I don't play cricket anymore. I had to give that up for injuries and time. But I still play sports. So I play tennis, squash sometimes. Hiking's my main passion now. So going out walking. I live near the Peak District. So still a big part of my life.
Excellent. I can't think of anybody better qualified to talk to and experienced for what we're trying to do, which is to look at how physical activity can play an increasingly important role in sort of health prevention and recovery and rehabilitation and stuff. So that's fantastic. So tell us a little bit, and John, you can come in here because I know you've got some experience of the centre. Tell us more about your current job. What does it entail?
Yes, so the National Centre for Sport and Exercise Medicine was an Olympic legacy project. So it's funding after 2012. And the main aim of it is to increase health through exercise sport. So treating exercise as a medicine. And my role specifically is about trying to embed physical activity in clinical pathways. So that's quite a broad remit, but that's kind of everything I do is with that aim. And what that funding was used to do is set up what we call a co-location model. So in 3 of the Sheffield leisure centres, part of the building is NHS. So we have consultation rooms, and they're designed to be the same spec as rooms within the hospital. So they're set up on the same IT system, same equipment, same infection control standards. Everything is mirrored. But the difference is you're not in a hospital with all the that kind of association with hospitals of being sick and not particularly uplifting places, to a leisure environment where you've got people there doing their aqua aerobics, doing their wheelchair tennis, having their coffee after, and it's that prompt of people coming in automatically feeling it's a more positive place, but also thinking, oh, could I join that class? Or they don't look too different from me. Is that something I could do? So it's all really about the design of the building and that journey from people coming into their appointment, what they're thinking about, how they're feeling, and how that affects their physical activity and how receptive they are to the health professional bringing it up and suggesting it, but then what they might be likely to do afterwards as well.
Okay. So in terms of that integration, would you say that there's been some progress over years? What's the learnings come out?
Definitely. So it's been running about 8 years now. So lots of learnings. One of the main intentions of the co-location is bridging that gap between the fitness, leisure sector and health. So having people in the same building is not just about the effect on the patients, it's about the effect on the staff. So they're also seeing those prompts. So they're more likely to then speak to patients and have that in the front of their mind during their consultations. Also, they can be active after work, they can use the facilities. So that there's definite benefits, and the feedback we get from professionals who come and look at the sites or work there is always extremely positive.
Yeah.
I show people around almost every week, and if
Right.
they haven't been there, they're like, wow, why didn't we know
Right.
this existed? How do we work here?
Yeah.
It's like,
Yeah.
waffle, there you go.
It is a very impressive. It's a very impressive facility, and it was very pioneering at the time, wasn't it? You know, I was involved. I worked for the operator at the time. We had the partnership with the city council, and I could distinctly remember being involved then and thinking and talking with colleagues from the NHS about the sort of groundbreaking, pioneering sort of nature of it, where you've got community recreation, elite sport actually as well, and health and wellbeing and the NCSEM, and it was going. I don't suppose anybody really knew how it would develop, but I'm interested in, you know, perhaps some of those deeper learnings. It is a very, very impressive venue, well located, but, you know, tell us a little bit more in detail about the learnings that have taken place.
Yeah, I guess some of the intentions haven't. Some of what was originally for has had more effect and some less of effect. So one of the ideas originally was that people would come in, and like patients would come in, and then they would then use the facilities and maybe get memberships, and that would be kind of that progression. But what's more like, because the way the NHS works, people are invited for appointments from far and wide. You know, that's the centre for the whole of Sheffield. So in reality, patients don't want to use that facility. You know, they don't want to travel 45 minutes for that particular gym. So that kind of conversion, it isn't as expected.
Okay.
But what has had more of effect is what I was just mentioning about that, the impact of those behaviour prompts and the environment, which is really crucial. And we've got 3 sites, and they're all designed slightly different. So in some of the locations we have separate receptions. So the NCSEM part of the building is a separate entrance and quite separate from the sports centre. And then at Graves Leisure Centre, it's all together. Everyone comes through, and as I was saying, you walk past the swimming pool and you see everything.
Yeah.
And in the ones where you don't have that walk, that effect is limited. So that the importance of having that shared reception entrance and people actually seeing on the walk, and there was a bit of kind of debate at the time, this is a bit nicer, it's separate, you know, people have a nice quiet entrance.
Yeah.
Well, that's true, but you don't get the effect.
It's really interesting actually, because I'm involved in a project at the moment looking at the MSK hubs, and there's a bit of pushback actually from the leisure client officers, who are saying we don't really want the NHS emblems and logos, if you like, in front of building. Their perception is that it'll take away from the leisure experience. It might detract, it might feel a bit sterile, a bit like going into a hospital, all the rest of it. So they want it sort of shoved out the back somewhere. So what, have I got that right? So what I'm hearing is actually it's better to integrate it.
Yeah, you know, you want it side by side, and to feel like the NHS belongs in the leisure centre, and it's not unusual for your health and fitness and leisure to be all joined up.
I mean, given that, Beth, I'm intrigued really, because everything's a journey, isn't it? You know, we start somewhere, and you know that's not where you finish. You continually evolve and develop, don't you? If you were to sort of forward, you know, say 10 years, what other changes could you envisage in order that we did get that deeper integration of physical activity into a care pathway?
One of the big things, it's been no surprise, is the finance and the funding. So the other big barrier and challenge we have at the minute is obviously leisure operators need to be sustainable and operate their business model, and that there's friction with NHS referring on if stuff costs, and that kind of conflict between the NHS can't be seen to be helping companies profit. So unless there's public funding which subsidises, and that partnership, it's really difficult to build those connections.
Right.
So yeah, I guess it is really that system approach of
Yeah.
how we navigate that. And yeah, I have a lot of debates about stuff being free and not free, and sometimes free isn't always good because it devalues it and all of that. But it's a way of making it, getting the support for the right people, but also sustainable for those leisure operators.
I mean, this
as
plays
well.
into the whole system leadership,
Just a tad.
doesn't it? Really, and we've got what it seems like there. We've got sort of transactional mentality getting in the way of improvements to population health. And how do we? It sounds like there's something around how do we collaborate across the system, NHS operators and what have you, develop a new business model in order that we deal more effectively with, we remove this sort of transactional inclination that unfortunately exists.
Yeah, and then there's also the workforce that comes into it, and that realization that the leisure sector can't fix all. You know, they can't replace physios or OTs or whatever, but where they can have the most impact is that maintenance phase and that long-term impact, secondary prevention, and that the skills they have in motivation and keeping customers effectively. That also helps with people's health and helping them in the long term. But that isn't recognised within funding cycles and systems. So there's a bit of a there's work already happening for health that isn't kind of recognised as health, if you get what I mean.
Yeah, I do. I mean, there's a number of things. Well, actually, there's loads of things that come out of this. It's interesting, the parallels with some of the discussions that we're having in Greater Manchester with the Prehab for Cancer and the expansion of that programme. And obviously, budgets are tight, and there's the principle of the NHS principle that is fiercely guarded, free at the point of consumption, if you like, for patients. And there's an increasing feeling that's going to get in the way a little bit, although we all believe in it. But it's like, well, but to make things sustainable, even from the clinical side of things, where does sponsorship? How do we get businesses involved without taking away that principle or diluting that principle from the NHS? So it's probably out of our pay grade, isn't it, to figure out? But it's a great to have it debated. The other thing that strikes me is, and it's a genuine question, in terms of evaluating the learnings. I mean, we're scratching the surface probably of what the learnings are. Do you know? Have you been evaluated? Have the learnings from what you've been involved in, is that influencing anything else outside of Sheffield, to your knowledge?
So one of the main partners of NTSEM is Sheffield Hallam. So they've done various bits of research on the model, started out of the concept and the theory behind it, and then who, what, and how it works. So that we've got that kind of learning at that level. We're at the stage now, particularly with the MSK hubs and this kind of realisation with health and leisure, that we want to share that learning more. So yes, we have got evaluations and stuff there pre-done. So anyone kind of interested in that would urge them get in touch, have a chat, and we can.
Yeah, excellent. Well, maybe
share.
we can help with that. We can get the links and whatnot on our website as well. So that's good. Yeah, good. Okay, so John, and before we move on to the Churchill Fellowship.
Well, I was going to ask about your studies in America, what tell us about that and what the differences and what might be applied here as a consequence of that learning.
Yeah, so I was lucky enough to be awarded what's called a Churchill Fellowship. So the tagline of the fellowship is "Travel to learn, return to inspire." So it's a really
Love it.
it's an amazing organisation. It's open to anyone. They really encourage people from different backgrounds, so they don't just want researchers. They want people who can make a change and who are passionate about their field. So my project was all about cancer and physical activity. So what I was looking at is what's the cultural and contextual differences between here in the US that make it more likely for physical activity and exercise to be business as usual, I've termed it. So just a routine part of cancer care. So I started off just searching the internet and then trying to find real examples of good practice. So in the US, even more so than here, it's very variable because they don't have an NHS. There isn't a standard approach. So these were really kind of isolated examples that I found, but they were, I was deliberately trying to find the best I could. And it was an amazing experience. So I travelled around for 6 weeks, visiting different programs, combination of clinical sites, community, and some that were academic led by universities. And loads and loads of stuff came out from the learnings. But one of the big themes that links to my role at NCSEM was about the facilities and the importance of environments.
Yeah.
Yes.
So some of the clinical sites in cancer hospitals, they'd basically set up gyms and facilities within their cancer hospitals. But the way they'd done it wasn't just, we'll put a gym in the back corner when no one can see it. It was, they deliberately designed, so you go through the reception and glass windows, there's your fitness centre. So every single person coming in for their appointment saw it.
Yeah.
And every single staff member coming in for their day of work saw it. And it was, you could see people on treatment there, being active, getting the support. And then the other side, you had the chemo ward, again, glass windows. So you're sat there for hours. You can look in, you can pop in, you can do a little bit, all with that kind of specialist support on site. And what that effect that had was, there was loads of effects. So one, the convenience, obviously, but it's that statement that this is front and centre, prime location in a hospital. Same as here, hospital space is limited, but it was sending out a message, we're prioritising, this is so important, it's getting this space on the ground floor next to the reception. And that effect of in the patient's and the staff's head, well, it must be important. Not just the one-off comment from a member of staff, or you should exercise. It's seeing it every day. So when someone does say it, it must be really important because it's there. And same when you're in your treatment, people are there every week nearly when they're on treatment. So that constant reminder. And then you've also got the closeness to the fitness staff, exercise professionals, and the oncologists, and feeling like they're in one team and joined up. So that's similar to what I was just saying with the co-location, of that trying to bring it together and add those prompts, but in a different way and in the clinical environment. That was a big learning, and how it's similar, and we're trying to approach it in a different way.
Excellent.
I mean, that's interesting, isn't it? I mean, the immediate, it just reinforces every time you visit that centre, the reinforcement of physical activity and the connection between physical activity and my treatment. It's just immediate, isn't it?
It is.
Yeah.
Just before we work off the Churchill Fellowship, if anybody's interested, I think it's September when they open for new ideas and this similar thing. So anybody listening to this might be thinking, oh, that sounds an exciting
definitely
thing.
Look it up. It's a really amazing opportunity.
And
they're open every year, so they say just keep applying.
Was UK Active a sponsor?
Yes, UK Active is a sponsor for there's different fields to it. So there's one field, physical activity, which UK Active.
Fabulous, absolutely fabulous. Just on that model as well, I think, as John says, I think it just reinforces what we were talking about earlier, what you're doing at Sheffield. I can't help but compare the sort of the Prehab for Cancer in Greater Manchester model as well, which is actually almost the reverse of that. It's actually using the facilities out in the community, so it's much more convenient in theory, and I think that's what we're finding for people to access. But the key thing that is very similar there is the way that the staff are integrated and respected, to be honest. How do you feel about that sort of learning from America? Is that something that was right up there?
Yeah, definitely. And it's how you achieve that, because in America it was achieved by them being in the same building. And it's my own experience with services, when they're community based, they can feel quite separate and not, it's again the transactional thing. We're referring on to this service rather than this is a part of your treatment. And it's a natural, if you get what I mean. And that's, being in the community creates that illusion, if you like, that it's I'm giving you to someone else. And then for the patient as well, I'm not sure, like, is that necessary? And
it's a potential for them to drop out, isn't it? And it's like, so that being, again, in GM, I think a crucial part is it's part of their pathway, and it's almost in sales speak, it's an assumptive close. It's not, you're asked, would you like, well, you sort of probably are asked if you'd like to, but it's assumed that you will do this. And the stats say, they will, actually.
And that's the real key to success, is that with these programs, is that it is embedded and it's standardized, and it's not on professionals judgment, if you like, or their preferences. So I like referring to that, so it's kind of gets over that and gives every patient the option. Obviously some will decline, and we've got work to do on that, and still raising the importance and the benefits on that level, but getting that standardized embedded is key.
So in terms of your learnings and taking on, have you got plans to take this learning from the work that you've done up to date? What's the next phase for you? What needs to happen?
So in Sheffield, we've got some place-based funding at the minute from Sport England, and part of that has a specific focus around connecting health and health systems. So we're currently redesigning our Sheffield physical activity referral scheme, and we will have a bit of a specific focus on the cancer pathway within that. So we've got existing services already, so a service called Active Together, so similar to Prehab for Cancer, and we've got community programs as well. And what I'm specifically interested in is how we join up those different types of support based on people with cancer and other conditions. It's complicated, it's complex, people don't fit into one box and one service criteria. And when services are commissioned and funded, there's always limitations around what they're funding and what their remit is, and it's kind of joining all that up to help the patient at the right time, the right support at the right time.
There's some fascinating stuff going on just at the moment around physical activity referral schemes, and obviously the nice view of physical activity referral hasn't changed since 2015, I think, and it's not particularly complimentary. And in England, we haven't got any standard approach or standards within physical activity referral. They've just established them in Scotland, and I'm wondering whether, and lots of people are reinventing their physical activity, and I wonder whether there's a bigger piece of work to establish it at a national level. What standards do we want across the UK and across England, because we haven't got anything around physical activity referral? Maybe that's your return to inspire bit.
So I am linked in with the work Move Consulting are doing around embedded physical activity, and I don't think that's specifically around referral schemes, but that's obviously one mechanism for that. But definitely there's so much variation, and what does could look like. So in Sheffield, we've been on this about 18 months already. So we'd had a bit of a co-production engagement phase where we'd got health professionals, providers together and kind of tried to get all this down. And we've just done what's called a Delphi approach with like 50 of those stakeholders to reach a consensus of the standards for Sheffield. So again, that's learning. We're happy to share and
Fantastic.
feed into national pieces. But yeah, we're conscious that other people are doing similar things as well. So
That's
And
probably
is that sort of developing criteria in terms of admittance into the scheme, debating issues around just clinical referral or self-referral as well, depending on meeting the conditions?
Yeah,
or,
so
talk to me a
what-
bit. I'm interested.
yeah, so we've got in Sheffield multiple providers.
Yes.
So that's been kind of ongoing for a number of years. And what was naturally what happened with that, there's slight variations on what was delivered. And that is good in a way because, they can develop their own unique approach. But for health professionals referring in, they didn't know if I send them there, what do they get offered? If I send them
absolutely.
there,
Yeah,
is
yeah.
there safe?
Interesting.
Is that, and it's kind of put that doubt. And when we're already fighting battles to embed this,
Yeah.
we don't need that extra
yeah.
hurdle for the health professionals to get over. So the standards are really kind of we'll call them quality standards. So we can be confident promoting to health professionals and service users. If you go to any providers, this is what you're going to get. This is the kind of quality
Yeah.
of it. So that's like the level of staff, qualification, and the amount of contact time and stuff like that. So that's the main aim of those standards. But what we've also found with the process is what was currently offered was a bit too limited, in that a lot of it was focused on leisure centres, and some people just won't engage in those environments. So we want to add in more less traditional venues and community stuff as well. So some people, leisure centres works brilliantly and they get those outcomes. And as we know, uptake and adherence is the main issue with the schemes. So we want to try and overcome that. And also in Sheffield, we've also got a very complicated social prescribing voluntary sector setup. So it's very localised, again, which is very good. Lots of benefits to that, but to navigate around it is difficult for health professionals if they're covering citywide and they want to get community support, and you've got 10 patients in 10 communities with 10 different offers. So we want to link in that type of support as well.
It's fantastic.
people-
I mean,
good to
there's-
hear.
It is good to hear, and can't help but think some of the discussions that we have in GM Active, we could very easily be replicating the work that you've just described there if we're not careful. So I think we need to make that link
Yes,
much
definitely.
stronger. That's one thing. But the other thing is, a good friend of ours, Mark Tweedy, posted something on LinkedIn only last week, which has got a reaction from Andy Reid, who's advising the Labour Party on policy, and he picked it up. And it is about this issue of standards on exercise referral schemes. So I think, and we're working with UK Active and Kenny Butler and things. So I think the time is to say, look, there's some great work going on in Sheffield. Clearly, let's bring everybody. And I'm no doubt there'll be other people doing exactly what we're trying to do, and what you're trying to do is get these standards up together. So I think we need to pull it together. That's something that we can do. So that's absolutely
definitely.
fantastic, Beth. Brilliant. Okay, so just workforce. A couple of things. Sport England, you've mentioned it a couple of times. Sport England investing quite a lot of money into place-based approaches and a whole systems approach. Leadership in particular, what's your thought on our sector's sort of ability to work in this whole systems place-based way? Obviously, Sport England are putting a lot of money into that, so they obviously think there's something that needs to be developed. But I'd be interested in your thoughts on that sort of aspect.
Yeah, I think it's really variable on the place, really, and I suppose, and Sport England has recognised this, the time it takes to be in that system and be in the right conversations.
Yeah.
And tradition, people from active partnerships or our sector traditionally haven't been in those conversations, so it's going to take time to get that recognition and be valued as system partners, I think. So yeah, I think it's very variable how far you are on that journey.
Yeah.
And yeah, individual leaders in that place and how bought into that they are, and making that change and their own priorities, really. I suppose we know as well, same with health professionals, when in the context we were just talking about, people's personal perceptions,
Yeah.
and their own relationship and experience with physical activity impacts on their professional perceptions of it.
I was going to ask you about that in terms of, it seems to me to be one of the challenges that we've got, where the traditional leisure sector, we don't necessarily like the word leisure, but might have a perception, and it might be negative, from clinical professionals or medical professionals, healthcare professionals, and how does that perception exist, and what have we got to do to change the way that we present ourselves and collaborate and connect with healthcare in order to do a good job that I think we can do.
Yeah, those perceptions definitely impact, and sometimes it could be someone's had a bad experience when they were 14 years old in a leisure centre, and those things have subconscious effects many years later. I would say one of the main things, and SimSpa is working on this, is having those standards for people in the industry and making sure that our workforce has the appropriate, I don't know if regulation's the right word, but that quality assurance to say, this is what our workforce is trained and this is what they're skilled to do.
Yeah.
And there's also been a bit of a shift in my observation of, the fitness sector could do this, that and the other, and you think, and that's very clinical.
Yeah.
And they're probably not qualified to do that. So it's getting past this kind of dumping stuff on the leisure sector, and really valuing what it can bring, like I said earlier, that long-term maintenance, keeping people engaged, rather than we've got loads of wait lists and we can't do it, can they do that type of mentality.
We're doing a piece of work at the moment on our own physical activity scheme in Stockport, and it's complex, isn't it? And the aim is to get the right intervention to the right person at the right time that's right for them.
Yeah.
And there is a difference between, some patients who get referred have got quite a high degree of clinical needs and others low. Some need quite a high level of support and some need a lower level of support, and it's about getting the right.
Yeah.
And there are those dimensions, and this sort of binary approach to things isn't right, and we've got to be a little bit more sophisticated.
Yeah, and
than
that's exactly what we're trying to do in the Sheffield scheme. It is add a triage that
we should talk.
Determines that risk level. And one of the things, when we looked at the stats, a lot of referrals were for anxiety and depression.
Yep.
But the referral schemes weren't ever designed for that. The qualification doesn't even cover it. It didn't when I trained anyway. So, is it right, someone with anxiety, sending them to a leisure centre without even asking them if they want to go to a leisure centre, first of all, and then with a member of staff who isn't even trained to work with someone with anxiety. So it's that the scheme hasn't evolved with the referrals it's getting.
It's interesting, actually.
And we've got an increase in those mental things that there's mental well-being and social connection needs that are relevant from a referral
Exactly,
perspective.
yeah. So there might be better support for that particular person.
Exactly.
But then on the flip side, it might be an MSK issue, and they might need that really tailored approach, and that facility and that instructor is perfect for them. So it's really getting
I think
getting that triage bit right.
The word complexity is what we're talking about, and it's interesting again, John, isn't it? I'm thinking of Michelle, the GM Active Lead, your health lead, working on this.
She feeds my brain.
She
is the brain.
Yeah, she is the brain. Yeah, that's right. But I think again, it just is screaming out, listening to you, Beth, of the collaboration, and I'm sure we can bring Sheffield and Greater Manchester together between us. But what about the rest of the country? And that's where the work that we're doing with Kenny Butler and UK Active stuff. I think we have to bring more people together to get this right, and build on the work that's gone on up in Scotland and Wales as well, and get that workforce piece right, and be, like you say, be realistic about what we can and can't do. And also with our sponsors, Future Fit, there's been a lot of discussion with Future Fit about what can the training providers do to actually speed up, if you like, and accelerate that the availability of qualifications and training that's required. Because if we wait quite often for the academics to catch up, we're waiting years for them to write new programs and things. Any thoughts on that? Or?
Yeah, I suppose this comes back to the system working as well, and we think of the system as your council, public health, your ICB, but there's all those industry partners as well that can have a role to play.
Absolutely.
So it's thinking broader. And who can contribute what to progress.
Can I go back to this discussion about triage?
Yes.
Do you see a role for technology in triage?
I'm laughing, because
we're all thinking the same thing.
So that's actually one of the things we're working on, is having a digital triage tool, using AI technology, to
we're doing the same.
Okay,
and we're only 40 mile apart.
We're kind of into that already, kind of working out how it's going to work. I've learned so much about AI that I never thought I would know. And our kind of rationale is that if we can get that working, the people who have got a smartphone and are capable of doing that themselves can go through that process and get that personalised recommendation. But we know there's going to be people who can't do that, and for whatever reason, digital exclusion, or they can't understand the language. So then we can use our human resource focused on that, and with the presumption that's the kind of greatest need. So it's just trying to future-proof it a bit.
Is there any cynicism within healthcare professionals about using AI to triage?
No, not yet. There might be when we get to the testing phase. I mean, we're at the kind of first phase, so the AI is mainly to kind of pull sources from the internet, and to one of the biggest things we had, which when we said about having more options, was multiple providers is keeping up to date and knowing all of that stuff, and how do we get that personalized recommendation. So that's what the technology is going to help us to do in this first phase. There's loads of other ways it could help. For example, like monitoring behavior and then tailoring and doing the kind of behavior change intervention through AI. We're not at that stage yet, but we've recognised that in future could be something, but it is really complicated. So within our...
It is, but I think there's huge opportunity. I mean, we're doing similar things, and we're trying to use AI and use the principles of motivational interviewing in order to see what effect that has on, give that at the onboarding experience within the pathway, and does that affect adherence and take up and those sorts of... It's fascinating. There's loads to do. But exciting.
Beth, we could be here for hours talking to you, picking your brain. Honestly, no, we really could. We're going to move on to quickfire questions in a minute. We don't necessarily mean quickfire answers, by the way, but quickfire questions. But before we do that, just going back to the workforce piece, really, and the qualification things, we skipped over the fact that you put yourself through everything through masters and all the rest of it. Is that right?
Yeah.
So did you self-fund all that yourself?
Yes. Yeah.
Was there something? Why? What drove you to do that? Can you remember?
Honestly, I think at the time I felt like I was very much in the fitness industry, and then I moved a little bit more into the charity sector, and now in NHS. But at the time, I felt like the opportunities within the sector were limiting.
Okay.
So I wanted to do that public health masters to kind of broaden my option and have more chance in the health sector, I suppose. I felt at the time it was kind of limited to moving up to centre management and that kind of path, which I wasn't really interested in.
Yeah. Okay.
So I think that was the motivation.
Can you articulate what your purpose is now? Have you got a burning sort of purpose in you that you could articulate?
Overall, it's helping people with health conditions to move more. I think that's the overall.
Yeah. Okay. Excellent. It's wonderful, and I just think that there's lots of. There's another podcast in my mind here about your career. I'll put you on to somebody who does a Love My Career podcast, which is another good one. But it's fascinating. I think you'd be a great role model for other people who probably have similar sort of underlying aspirations to help people in that way. Anyway, quick fire questions for all. What one thing would you wish an incoming new government of whatever colour to do in relation to what we've talked about today?
Oh, that's a tough question. I think it's what I mentioned earlier about the flow of funding and money through the sectors, and moving away from that transactional. We're going to commission you to do this service and give us these outcomes, and recognising that long-term impact the sector can have on someone's physical activity in the long run. Same as health money. So
here.
Yeah. I don't know how to do that, but yeah.
No, that's what we're trying to navigate. But share your aspiration.
Bit of a paradox question. Obviously, we're all three of us excited about the future, but what opportunities do you see in the future? But also, what fears might you have about achieving those?
I think the opportunities in this space are just endless, really. We're really at the start of the journey, especially something like cancer, which I focused on a little bit. I always compare it to cardiac rehab, and in the 1950s, people after a heart attack were said, stay in bed for a year.
Yeah.
And now we've got, cardiac rehab's completely normal. It's completely embedded in the health system. Still probably improvements and things that can evolve, but it's business as usual. And that's how long ago is that? 70 years ago? Yeah. So we're almost 60, 70 years behind in other pathways. So it's kind of following that trend of a lot of health conditions. It's, rest, I'm not sure, is it safe? Do you need a doctor's note to making it normal? And that whole infrastructure around that needs to grow and develop, which is exciting.
Final quick fire. we currently our sector sits in the DCMS. Do you think it's the right home for us, or should we be moving over to the Department of Health and into OHID or something like that? Any thoughts?
Ooh, I would say the Department of Health.
Yeah.
Yeah, and this is another long debate, probably about sport, the word sport, and the the perceptions of that, and the and what that means to people. My opinion would be the Department of Health, but I'm sure that
Mine
others
too,
would disagree.
but not everybody's. Not everybody's. Okay, that's fantastic. And all it remains now is, can you think of anybody that we should talk to on the conveners to continue the conversation that we're having? Anybody come to mind?
Yeah, I mean, there's loads of people in Sheffield doing similar work. Marlies DeVivo, who's our programme manager at National Centre, who also is the founder of Active Pregnancy Foundation, so a lot of work specifically on that pathway and that world. Probably hundreds of others.
No, that's fine. We're trying to limit people to one.
Spot,
that's fantastic. And I think, John, I mean, I'm just inspired. I've never been over there, and I think if we could, maybe we could ask you to host us, or we could get somebody to host us in Sheffield and actually see a few people. Actually, I think it's really important. So that's a fantastic start to our day, John. Do you
it was a brilliant start, and I mean, I'm bowled over really. I think the sport thing is really interesting because there is this perception of sport that gets pushed back, but you know, all three of us have got are where we are in our careers, and it started by being inspired by playing sport and what have you. Yeah. So you know, we shouldn't dismiss it. It's just moving about in a different way, and you know, we value it. It allows us to value it, I think.
Yeah.
And then, but to move then into actually caring about the value of physical activity from others, the starting point was sport. I think we should celebrate that and not sort of veer away from it really, or excuse ourselves from it.
Yeah, it's interesting.
But it's a great, it's a lovely chat. Yeah, and I think we should go to Sheffield because there's.
We'll go to Sheffield, and we'll also make the links. And Michelle Childs from GM Active, John's health lead in Stockport needs to meet Beth and connect. There's so many parallels. But thank you so much.
No, thank you for having me.
Brilliant.
Thank you.